Ronnie, your book talks a lot about caring for patients that have dark skin. And one of the problems that patients with dark skin have is keloid formation. So a lot of the topical treatments that cause roughening up of the skin probably would not be a good choice for an African American, for example. Other variations of skin are brown spots on the conjunctiva. A lot of parents are worried because there's these little brown dots on the whites of their eyes, but that's just excessive melanin. It doesn't hurt anything and it doesn't mean anything. And you see a lot of melanin in thicker skinned areas like the knees, the elbows. They're darker. There's a thing called Fuscher line or Ito line that separates the back from the front, which I honestly had never heard of or seen. I'm going to have to try to notice that a little bit better now that I know that exists. The skin reacts differently when you're looking at dark skin. If it exfoliates, it can look gray. The papules, because of the pressure up on the skin and black skin races, can look white rather than pink. So instead of papules that are pink, you can have papules that are white. The atopic dermatitis may actually hypopigment, and the redness to their skin may look purple. And there's variations in coloring from one part of the body to the next. And you can see that on this little boy. That his nose and his forehead and upper on his cheekbones are white, his chin's a little white, his ears are whiter. So you can get some color variation in that kind of a situation. So some practices that can have some consequences for skin in the darker skin races are a thing called hair pomade, and it can contribute to acne. It's actually a greasy, waxy, or water-based substance that is used to style hair. It gives hair that slick appearance. You've probably seen it used or used it. Bleaching creams discolor the skin and can cause some red nodules to form. If you tightly braid your hair or have deadlocks, you can have traction folliculitis. Henna for superficial tattooing can cause you to look like an orange. Decorative practices can cause scars and keloids like tattoos, piercings. Healing practices that produce burns and coining can cause petechiae and ecchymosis, and cupping can cause circular ecchymosis. So here is a little girl that has vertigo, where there's just a discoloration, loose white patches on the skin. It's really an autoimmune disorder in which pigment-producing cells are damaged. There is no cure for it, and some people use steroid cream or ultraviolet light therapy to help with it. Tinea versicolor is another condition called Peter Elam's disease in South Africa. It usually has a reddish undertone to the skin that can darken when the patient's overheated. Tanning makes it stand out more. It's really more common in hot, humid climates and in those who sweat more. Yeast has spaghetti and meatball appearance under the microscope, and in white people actually can hyperpigment. Diagnosis is by the potassium hydroxide preparation, and lesions appear copper orange under the wood lamp. Another condition where the skin gets white on dark-skinned people is pityriasis alba. And all of these three are really difficult to diagnose because it could be either one of the three. This particular one is a common skin disorder in children between 3 and 16 years of age. The face and cheek are common sight like you see this here. Initially, the redness may be conspicuous and minimal serous crusting of some lesions may occur. You can again use a wood light and it will glow more brightly. Then tinea vesicolor will be positive when the potassium hydroxide is used. It's a benign, this condition is, and many use low-potency steroids, tar paste for the trunk, bland emollient cream, PUVA light, and the Keloid ointment, and PIMECROLIMUS cream has been effective for this condition. Laser therapy twice a week for some people works for 2 weeks, and it progresses from the popular erythematous, papular hypochromic to a smooth hypochromic area like you see here. So you can see that the three conditions all bleach out the skin. They're very difficult to differentiate. The most you could hope for is under a wood light, you will be able to see a change and be able to diagnose fungus infection. This is coining. If you've never seen it, this is what it looks like. It begins with a massage using a warm oil that is mixed with warming essential oils. Common essential oil choices are peppermint, cinnamon, orange, wintergreen, eucalyptus, or menthol oil. Some practitioners use tiger balm for another warming ointment. The goal of the oil is to irritate the skin slightly, warming it for the next stage of the process. The massage relaxes the patient, bringing him into a state of centered stillness so that the next segment of the treatment will be more effective. The coining treatment continues as a coin is repeatedly rubbed against an area of the skin in long, flowing moves, which always moves away from the heart. Blood begins to rise to the surface of the skin and will leave a mark that resembles a bruise or love bite. The areas of the body that are most frequently treated are the back and ribs, and the marks will fade a few days after the treatment is over. Have you ever seen this? No, me either. But, I mean, you could imagine if you ever saw it, you would think it's abuse, right? But this is another thing that you might see. It's called cupping. It's an ancient form of an alternative medicine treatment in which local suction is created on the skin. They believe that this mobilizes the blood flow in order to promote healing. Suction is created using heat, fire, or mechanical devices, hand or electrical pump. So that's what, and you can imagine once those are released, you're going to have red spots on the skin that correspond to where the cupping took place. Jessie is a 1-year-old and is coming to your clinic with a skin issue. What are going to be your questions? What are you going to ask the parent of Jessie?
How long has it been there?
Pardon?
How long has it been there?
How long? The duration? What else?
Does he have a fever?
They have a fever? Okay, so you're looking for some systemic symptoms that might be present? What else?
Have they applied anything to the skin to make it better?
Absolutely. Is there any treatment, and if so, has it made it worse or better? What else would you want to know? What about it? Has he ever had this before? Oftentimes, skin conditions repeat themselves, so you might want to know if he's on any medicine, too. It could really be a serious thing, couldn't it? If he were taking medicine and this resulted from the medication. So you might want to know if they've traveled anywhere, if anybody in the family's ever had anything like this. What body parts are affected? Has it been exposed to anything? Would all be questions to ask. You might want to know, is the child ill whenever you do the physical exam? You're trying to find out, after you do the history, you're trying to find out if they're sick. Pay particular attention to the eyes, nose, mouth, lymph nodes, lungs, scalp, hair, palms, soles, nails, and anogenital regions. And it's important to be in the daylight because direct light is even better. I used to have and still do a magnifying glass with a light that, made it even better to be able to see rashes. You can use rulers, glass slides, wood lamps, and there's an example of a wood lamp and the effects that you might see if they have fungal infection. So what do you want to chart? You want to chart where it is, what it looks like, the size of it, the shape of it, how it's arranged, the pattern of it, is just some sun-exposed areas, the distribution, is it in one region, is it generalized, is it in crops, what's the border of it, is it well circumscribed, can you determine where it begins and ends, in other words, and the consistency, is it firm, soft, or mobile? Those are all questions that you might want to chart. These are sites. I won't play them tonight, but if you've never done skin scraping, they will walk you through skin scraping. Both of these do them for different things, and so the procedure is different for the two things that they're looking for. So I would encourage you to watch those on your own. We really don't have time tonight to look at it, but it is there for your use. So when you're looking at skin conditions, some of the management strategies are hydration and lubrication. Bathing, you always want to tell parents with children, especially like with eczema, to lubricate at the end of the bath, pat dry. Don't stay in there till you're pruned. And baking soda and oatmeal baths do help itching. Humidity that's greater than 90% or less than 10% is not good for the skin, so you might be aware of the climate. Use non-allergic mild soaps like, Ivory. Moisturizers and lubricants are usually petroleum or lanolin-based, and you can use wet dressings, and there's your frequency and solution. And steroid creams can be used under wet dressings with dry dressings over it. That's just another way to try to get the medicine into the site that's affected. Plastic wrap over affected areas will make the topical medication go on in. Don't leave it longer than 8 hours. Avoid wool, sweat, and saliva. Milk, eggs, wheat, tomatoes, citrus, chocolate, fish, and nuts are all allergenic foods that you might want to stop them having for a week. Do a trial of that and see if it improves, and then add one at a time per week. In sunscreen, you use factor 30. Apply 30 minutes before you leave, and don't get out in the sun if you have sun problems between 10 and 4, because that's when the sun is at its peak and most likely to burn you. Of course, that's when people usually go out and sunbathe. Medications, there are many preparations for topical, and your box 37.5 in this particular chapter shows that. And it also gave you, I thought this was interesting, if you have something, what should you use on it? So if it's acutely inflamed, those are the things you should use. If it's chronically inflamed, then it gives you the different kinds of things that you can use that would work better for chronic versus acute inflammation. And then, of course, they have to want to use it. You know, if they don't get better, a good question always to ask, why are you doing it? You know, actually doing it. There's lots of medications, antibacterial agents for some skin problems. Avoid neomycin if you can. Antifungals are used with caution in children. I think, you know, depending on what source you're looking for, anywhere from over 8 to 12 weeks, you probably need to get some lab work to make sure their liver is going to be all right. Antiviral can actually help, topical with herpes and acyclovir for things in the mouth. And then, of course, there's wart therapy. Anti-acne agents, some of them you have to watch because they can have teratogenic effects. And benzoyl peroxide and ricinic acid are the first lines of treatment with regard to acne. And there are some select birth control, orthotricycline, Yaz, and Tetrastrep have been recommended from the FDA for treatment. Topical antibiotics would be things like clindamycin, erythromycin, oral antibiotics, tetracycline, doxycycline, minocycline, erythromycin are all used in acne. Anti-inflammatory agents are used, creams. Ointments are better than creams, than lotions, than foams. Those are the strengths more likely to stay in place. I always use the lowest potency in the shortest period of time. And side effects can include skin atrophy, increased fragility, hypopigmentation, secondary infection, acneiform eruptions, folliculitis miliaria, and this is a picture of hypertrichosis, which is excessive hairiness above and beyond what's normal for the patient's age, sex, race, in contrast to things like hirsutism, which is excessive hair growth in women. Telangiectasis is spider veins. So anti-inflammatories can cause all of those problems. And when, you know, this person grows up, he looks like a werewolf. Medications, antipyretic agents like antihistamines help with itching. Topical ones should be avoided. There's some immunosuppressive ones that should not be used under 2. Scabicides and pesticides are used sparingly in children, but they are used for 2 months and older. Lindane, no more. Honestly, for life, mayonnaise, just saturate their hair with mayonnaise, put them one of those shower caps on, and let them sleep in it overnight. It doesn't harm them. It helps their hair consistency, really, and it's not going to kill them off with cancer. There are hair and scalp preparations for psoriasis and dandruff and all of those things that are over-the-counter, many of them. So lots of nits, if you've never seen nits, all nits must be removed for the treatment to work, and there's a picture of a louse. And it's not uncommon to see this in the pediatric practice. Watch for the little eggs in the hair. They are hard to get out, but you can use a fine tooth comb, and they have to be removed. They have to go. Just wear gloves. Be careful with yourself. Okay, Joey is your 3-year-old patient. He has been well up until this past week when he developed a sore on the corner of his mouth, which has become crusty and honey-colored. He says it itches and he just has not felt well. He has a history of trouble with eczema and has had recent breakouts. Mom thinks he's been scratching himself, and now he has an infection. No one else in the family has this lesion, and he has a brother that he sleeps with in the same bed. Mom is worried about his brother. What does he have, and what will you do for him? So what do you think he has? Honey-crusted lesions. What do you think that describes?
Impetigo?
It does. It does. That's what he has. And because of the resistance to antibiotics now, they really recommend using mupirocin, not multiple areas, so no oral dosing because he just has it in one place. But if he had multiple areas, you could use cefalixin, dicloxacillin, toxicillin, or clindamycin. MRSA should be considered if they don't improve in a week. Me to educate the mom about cleanliness, hand washing, spread of disease. No stool for 24 hours, and then you do need to follow up with these patients in 48 to 72 hours if they're not improved. This is a very common thing for little kids to have. Another thing you might see under the age of 5 is the scalded skin syndrome. The blistering disease that's causing staph. It has an abrupt onset of fever and tender erythroderma and neck folds and axilla, rapidly becoming crusty around the eyes, nose, and mouth. There's peeling of the skin with a light rub to reveal a moist red surface, so their skin just literally peels off. And it's treated with IV, dicloxacillin, penicillinase, resistant penicillin, first or second generation cephalosporins, clindamycin. And steroids should be avoided as well as minimal. You should do handling of the skin no more than you absolutely have to. Oh. And here's a picture of a little kid with scalded skin syndrome. You know, it's all just like the top layer of their skin goes away. Really sad situation. Usually causing staph. Tommy is a 3-year-old leukemic patient. Tommy has been bitten by a spider 3 days ago. Now he has fever of 102.2, pain, malaise, irritability, anorexia, vomiting, and chills. The spider bite area looks tender, bright red, with sharp margins and an orange peel look and feel. The bite was near his right eye, and it looks swollen all around his eye. What are you going to do for Tommy? What does he have? What do you suspect is causing his problem? And what do you think will be done for him? And what are his complications? So what does he have that would make you think that you need to do something a little bit drastic? What's involved that could send him to the hospital? It's actually covered up in this picture. You can't see it. What's he got? Does he have periorbital edema? He does, doesn't he? So that would be enough to send him to the hospital. He has probably erysipelas, which is a superficial cellulitis, usually caused from strep or staph, and he will need IV antibiotics. If strep, penicillin, or cephalosporin, and if staph, clindamycin. So you have to worry the complication for this little child will be toxic shock syndrome or necrotizing vasculitis. So he does need to go to the hospital. And here is necrotizing vasculitis. This picture was of a cesarean wound. And it's just like strep, you know, eating flesh is what that can be caused from, that you hear of, you know, being really taking away the skin and muscle down to the bone of people, legs or whatever. And then toxic shock syndrome was the other thing. Let me shut the door. My dog is showing out. Toxic shock syndrome begins as acute febrile illness with rapid onset with fever, vomiting, diarrhea. The blood pressure drops, and then you get this macular sunburn like rash that you see this little boy have. And then he goes into multi-organ system involvement with staph and strep as a causative agent. It doesn't take long, 14 hours, and they're in full-blown toxic shock. And there is higher mortality with strep. And you think of this condition more with girls, you know, that don't change their Tampax, leave it in for longer than 2 hours, and then they get sick. Here's folliculitis, which, if it progresses, it can become a furuncle or a boil. It's really a superficial bacterial inflammation of a hair follicle. It can be caused from staph, Pseudomonas, or E. coli are the more common culprits. Sometimes it comes from hot tubs. Treatment is warm compresses and keratolytics such as benzoyl peroxide, topical antibiotics, and if there's resistance, then you may see doxycycline used or ceftriaxone. So you need to follow up in 1 week, because in 1 week for folliculitis, but in 1 day for a furuncle you need to follow up because they might need an incision and drainage. Follow-up's important. Mom brings Jamie, an infant, to you because of a rash. Jamie's rash is in her diaper area, and the mom says that Jamie has not responded to the usual diaper rash medicines, but seems to be getting worse. She noticed some white spots in her mouth as well and wonders if the two are connected. Upon examination, the rash seems to have satellite lesions, and she notices Jamie scratching her bottom. Mother seems devoted to her and does not appear to be the kind of mom to neglect her children. So what would you think she has, and what are you going to do for her? How do you know it is not MRSA? Where do fungal infections live best, and so what could you tell her mom? So what do you think she has? Do you have any idea? One of the things that you want to ask if she's been on any antibiotics lately, because what she has is thrush, which should convince you even more that she has candidiasis, staph, dermatitis, rather than MRSA. Oral nystatin suspensions will be used for her thrush, or if it's resistant to treatment, then fluconazole. Topical antifungals like nystatin, iconazole are applied to her bottom, and let her bottom air or blow dry with a hair dryer at each diaper change. Just don't burn the baby. Watch pacifiers because they're oftentimes re-entry points for fungal infections. But never rule out the fact that you can have MRSA diaper rash, just because that's the really brilliant red bottoms without the satellite lesions are oftentimes MRSA. So just be aware, be cautious. It's not the simple diaper rash anymore. It used to be. Jessie is an African-American preschooler who's coming today for hair problems. Mom brings in Jessie because the teacher feels like he has head lice. He scratches his head a lot, but the teacher has not seen any louts. Jesse is a very active young man who is especially fond of gymnastics, wrestling in particular, and is quite good at it. The exam shows oval flat scales with red borders on his head, and there is circular hair loss. What are you going to do to diagnose him, and what kind of treatment do you recommend? What is tinea cruis, and would you want to rule that out, and why? So what has he got? Do you think?
Tinea capita?
Absolutely. So he needs some topical antifungals to begin with, but due to curly hair, he may later on need something by mouth. But you can use miconazole, clotrimazole. It may take a month to get it gone. If it's recalcitrant, then you do have to give him griseofulvin by mouth for 4 weeks. And if you do that, a CBC, liver, and renal function test should be tested if the treatment goes on for 8 weeks. Exclude from school until 24 hours after treatment has begun. Follow up in 2 weeks, and you do want to check him for tinea cruis, which is jock itch, because of his wrestling activities. He can pick up some fungal things in the gym. Here is herpes simplex. Herpes simplex 1 affects the oral cavities and eyes, while herpes simplex 2 affects the genital areas. So if you ever saw a kid with it in the genital areas, you need to think about sexual abuse. Viral cultures are the gold standard to diagnose it, and you have to rule out things like aphis stomatitis, those little aphis ulcers you can get from eating things like too much citrus, hand, foot, and mouth disease, varicella, chickenpox, impetigo, folliculitis, and erythema multiforme. So you can use Burrows solution on all these little crusty areas, and acyclovir. Acyclovir has that unusual dose of 20 to 40 milligrams per kilogram per dose, orally 5 times a day for 5 days, with a maximum of 1,000 milligrams a day. Sometimes you have to give antibiotics for secondary infection, and you can do a miracle mouthwash with lidocaine, Benadryl, and magnesium hydroxide and call it a miracle mouthwash. And if you replace the lidocaine with nystatin, if the child's under 7 and unable to spit it out after rinsing his mouth. Children 7 years and older usually can swish and spit. Under that, they may swallow. Verruca or warts are caused from HPV viruses, about 100 HPV viruses out there. Trauma precipitates the infection, so that's why you see it on hands, fingers, elbows, plantar surfaces of the feet. Transmission from fomites, skin-to-skin contact, and also inoculation. So you can spread it. A lot of times you want to do watchful waiting because even if you removed it, the recurrence rate is high. Suspect, again, sexual abuse if they have genital warts. And what are you going to do with your patients with warts? There are keratolytics over the counter that cause little pain, and they produce like an inflammatory response with peeling. The salicylic acid, retinic acid. So another thing you can do is you can cover them up with duct tape and cut off their oxygen. And your book tells you for how long to do that. Or you can freeze it, surgically excise it, laser it, take Tagamet, interferon, there's creams. There's like a zillion ways that you can treat warts, but most of them will go away on their own if you leave them alone. Arian is a 5-year-old that appears in your clinic with a rash. Arian complains of intense itching especially at night, and is in a cranky mood, which is unusual for her. The rash is in the webs of her fingers and is a vesicular rash. There are little burrows in the web of her fingers with a small black dot at the end of the burrow. What are you going to rule out, and how do you intend to treat it, and what kind of education are you going to give the family? So first off, what does she have?
Scabies?
Absolutely. And you can diagnose this with skin scraping, or you can actually use a washable felt tip pen and make the mark over the burrow so that you can see it more clearly. So permethrin from neck down, washed off after 8 hours, is a treatment. You can repeat it in a week. Ivermectin can be given if the case is recalcitrant and the patient's over 5 years of age. Antihistamines and hydrocortisone cream for itching. And you should tell the parents to vacuum the house, wash the clothing and bedding in hot water if they've worn it or been there in the past 48 hours, and store non-washable items in plastic bags for a week. Treat the entire family, and then after 24 hours, they can return to school. Moving on to acne, what contributes to acne? These are the 4 things that have to happen for acne to occur. So the sebaceous follicles have to be plugged with a keratin material. Then the bacteria invade the follicle. The sebum is overproduced and androgen production increases. Then you get the inflammation and pustules form secondary to the trapped bacteria, and you get white blood cells released as a result of that. And here are the types of acne. You can have papules, pustules, nodules and cysts, blackheads and whiteheads, for all types of acne that you can have. The goals for management of acne are to reduce the sebum production, counteract the shedding of skin, decrease the proliferation of the bacteria, and prevent or decrease scarring. Those are the goals, what you would like to do for your patient. The treatment is keratolytics such as retinoids, benzoyl peroxide, topical antibiotics like clindamycin, erythromycin, and oral antibiotics like tetracycline, erythromycin, minocycline, and doxycycline. And I think doxycycline is a cheaper medication for your patients. Here is the video on the latest research for atopic dermatitis, and she gives a really, if you're interested in that condition, she gives a great summary and little tidbits that you wouldn't think of with regard to that. Judy is a 16-year-old who comes to see you. She's a young woman who started a new job and is so excited about what she is doing. She works as a receptionist for a law firm and has been there about 2 weeks. She is coming today about a rash on her forearms which really itches. She has no idea where she got it and wants to get rid of it. It is on the underside of her forearms, both of them. What kind of questions are you going to ask her, and what do you think is going on with her?
When did she notice the rash?
And she says that it's been there about 2 weeks. She's been there about 2 weeks. It doesn't really say when she got it, but we'll have to say that she got it after she went to work. So what do you think causes it?
Maybe something she's exposed to at work, like a chemical.
Right, because it's on the underside of her forearm, so that's where her arms would rest on the table, wouldn't it, or on the desk. What's wrong with this boy? do you think? What does that look like to you? That is actually urticaria, allergic reaction. You've got some angioedema going on. So the treatment would be to remove the offending substance, give him some oral antihistamine, and maybe epinephrine up to 3/10 of the 1 to 1,000 strength, and then follow up if not improved in 48 hours. So he's gotten into something that he's extremely allergic to. Here is erythema multiforme, which is really a benign disorder. It has target lesions that form multiple concentric rings that you're looking at, and it usually comes after an infection from herpes or cytomegalovirus or HSV virus, and it's the only treatment supported with mild analgesics, soothing mouthwashes, debridement of the oral lesions, IV fluids, and sometimes oral acyclovir if they need it. Psoriasis has like little scaly patches, and I did put on the news a site that talks about the latest discovery with psoriasis and what they think is effective in the gene pool to be able to get it. And the treatment is steroids and ketoconazole. Pityriasis rosea, which is very itchy. If you've ever had it, it starts with a Harrow patch, and then this is the Harrow patch, by the way, and then this macular papular rash spreads to the rest of the body, and on the back it looks like a Christmas tree pattern. Some people have it in their mouth, and so you can apply calamine lotion. Don't go out in the sun because that makes it worse, and even sometimes oral erythromycin helps. It occurs now in the fall and early winter, so you might see this in adolescents now because this is the time of year when you might see it. Here's lichen striatus. It's a linear, shiny, flesh-colored papules with adherent scales, limited usually to one extremity. It will generally resolve in 1 to 2 years, so it's not contagious, and it's pretty much self-limited, meaning it'll run its course and then go away if you ever remember it's just on one leg or one extremity. Keratosis pilaris is chicken skin is what it looks like. It's found on the extensor aspects of the extremities, usually on the arms, upper arms. It too is a benign disorder, and you put lotion. There is a medicine called lacthydrin, which is lactic acid or salicylic acid, urea creams, and retinoids. And so what you're trying to do is take the tops off of those little lesions so that they'll heal. And it's not contagious. A lot of people have chicken skin. Here's the salmon patch seen on this little baby. It can be seen on the back of the neck, the forehead, or the upper eyelids, and it usually fades by the time they're 5 or 6 years of age. And there is no treatment for it. You don't have to do anything with it. Here is a port wine stain, little purple-red macules that occur unilaterally and tend to be large, like you see they're usually on the face, on the neck, and maybe on the extremities. And if the forehead and eyelids are involved like there is in this little boy, there's a potential for multiple syndrome. Here's a mangiomas. On the left is a strawberry hemangioma, which is superficial. And on the right is a cavernous hemangioma with a blue tinge. You can use steroids if they're interfering with functioning. You know, you can find them anywhere, so you might want to use steroids. Some of you had never seen Mongolian spots. Here is a Mongolian spot for sure. And they can be anywhere on the body. They don't have to necessarily be in the lower back. And they do usually fade with time, believe it or not. And they're seen more on dark-skinned children. Here's cafe au lait spots. If you have large ones, and there's 6 or more of them, and the child's younger than 15 years, it too can be a sign of many syndromes. This little spot right here is what we're talking about, this little brown discoloration. Is a cafe au lait spot. Here is a a monocytic nevi, a mole, and it is a halo nevi. Watch all nevi because, of course, they can become melanomas. But this one, as you see, has a halo around it. There's all kinds of types that your book talks to you about. This is acanthosis nigricans. It's the neck and the neck area is like a leather-like appearance. When you see that, you need to think about that there's an underlying problem. It might be an endocrine disorder or obesity or their own oral contraceptives or even malignancy can be seen with that. This is Higgins. It's small brown or black macules appearing on school-age children. They can be associated with several different syndromes, so you just need to be aware that something else may be going on with the child. What's going on with this one? What she got? Say.
Freckles.
Absolutely. And they're usually seen sun areas, places where the sun's exposed. Nothing wrong there, huh? Here's alopecia areata, baldness, where you lose your hair for no good reason. And so a lot of times you need to refer them to the dermatologist. And there actually is a National Alopecia Areata Foundation that you can refer them to, because you can imagine that would be pretty upsetting. Here is a fungal infection of the fingernail. Becomes thickened and yellow with debris underneath it. And again, treatment may take a long time to get rid of it. And you can use all the same kinds of fungal things that we talked about earlier. And here is inflammation of the fingernail, around the fingernail or toenail. It's usually caused from strep, staph, fungus, or herpes. And you can find out what it's caused from by culturing it. Another thing to rule out would be herpetic whitlow, which you can get if you're exposed to herpes. And you get it on your hand, like something like this. If it's really bad, they may have to take systemic antibiotics. And if it's purulent, then you just loosen the cuticle from the nail around the bottom and have them soak, warm soak. But they should wear, if it's on their toenails, wide-toed shoes, trim their nails straight across. And then if there's a problem, you may have to laterally remove a portion of the nail if it's recurrent. And do follow up with these in a month. This is on an extremity and can, become gangrenous if you're not really careful. And we ran over a little bit. But that is all the slides and all of the things that I could find pictures for in your book to make it come a little bit more alive for you. Okay, and I think there's several things in your course that would be helpful to you as well. And I appreciate you being with me tonight. I'm sorry about the late start. We had a little rough beginning, but we managed to make it through the first one and a little bit later on the second one. So I apologize for that, but I got you out 2 minutes later. So and we went through. We saw a lot of stuff. It's okay. Y'all have any questions of me or about the course? Anything that you are having trouble with?
So Dr. Mars, just a quick clarification for the assignments this week.
Uh-huh.
So we don't have an assignment, but we still do in the news, like a news article?
Yeah, I will be, and this should go on the record for everybody. A lot of people did their one posting last week, so I was afraid that we would run out of in the news things. So I will be posting one in the news in the where the assignments are. I'm sure you saw them. So that if we don't have anybody, like if we go on down through the week, then you can respond to mine.
Okay.
That I'll put in the course. But I was afraid, I didn't take time to count how many people, because I haven't read them yet, how many people had already done that assignment. But I'm sure a lot of people got it out of the way right away, which was fine. And you do 5 postings through the semester total. So
Okay.
you only have to respond 5 times to somebody's post. But because I was afraid now we might run out of postings, I will be posting at least one in the news that corresponds to the topic we're talking about every week. So if we run out of people doing postings, you can always look back at mine and respond to it.
Okay.
Does that help clarify?
That's a helpful clarification.
Okay. It's not a big deal. You just do one and then you react to 5 others. The whole semester you only do 5.
Okay.
Not bad. Okay.